Assalamualaikum warahmatullahi wabarakatuh and very good evening to Misty and my fellow friends. My name is Muhammad BUSTAMAM bin Sohaimi. My ID number 012-022-021-843. So today I'm going to present a case study about WOLF-PARKINSON-White syndrome and especially and focus more on AVRT, which is AV re-entry tachycardia. So we go to the presentation. So this is my table content. So first I'm going to explain the introduction, what is a WPW, and then go to pathophysiology and the etiology of WPW, and the case study, which is the main part, and the conclusion. So we straight away go to the intro. So what is WOLF-Parkinson-White syndrome? WOLF-Parkinson-White syndrome is a cardiac disorder due to presence of one or more accessory pathway in the heart conduction system. So this can cause arrhythmia in patient. So there will be a lifetime risk patient will having malignant arrhythmia and sudden cardiac death. Okay, so how it happened? So the pathophysiology is due to pre-excitation of the heart. So pre-excitation is the term for the early activation of the ventricle as a result of impulses that bypass at the AP, which is accessory pathway. So as we know, the normal heart conduction system is start from the SA node and then goes to the AV node through internodal pathway, which is middle, anterior, and posterior. And from the AV node, it goes to the bundle office and goes to the Purkinje fiber. However, instead from the AV node, it goes to the bundle office. This impulse will goes to the accessory pathway, which means it bypass, it not goes to the normal conduction system. So this accessory pathway also known as bundle of Kent. Okay, so how many type of pathway in the accessory pathway? So there is 3 types, which is in both direction, and the second type is retrograde, which is the accessory pathway it conduct away from the ventricle, and the anterograde, which is toward the ventricle. Okay, so this WPW can develop tachyarrhythmia. So there's 2 types of tachyarrhythmia that can cause patient, which is atrial fibrillation or atrial flutter due to retrograde accessory pathway. So as I already explained, retrograde means away from the ventricle. So it means from the SA node, it goes to the AV node, and then the retrograde, which is away from the AV node, it goes enter back to the atrial. So it causes the atrial fibrillation or atrial flutter. So due to direct conduction from atria to ventricle via accessory pathway bypassing the AV node. Okay. So the last one is atrioventricular re-entry tachycardia, AVRT, due to formation of re-entry circuit involving the accessory pathway, which is the anterograde that I already explained, the accessory pathway that form towards the ventricle back. So means from the AV node, it goes to the Purkinje fiber, and then the accessory pathway form, which from there, the ventricle, it goes back to the AV node, it starts back. So it can cause the atrioventricular re-entry tachycardia. Okay. So how to differentiate? Oh, so sorry. So WPW can be occur left, right, and septal. So how to differentiate of these 3 types? So based on ECG. So how to the first one is the left-sided. So the characteristic of WPW is delta wave, right? As we all know. Okay, so the left-sided, it shows a positive WPW. A positive delta wave. As you can see here, it goes upstroke. While for the right-sided, the delta wave will be downstroke, which is the negative. All of this we can differentiate at the V1 in the ECG. However, in the septal, it either positive and negative. You can see here in between the blue line. Okay. So this is example of WPW of left-sided ECG. So this ECG is a sinus rhythm with short PR interval with less than 120 milliseconds. So broad QRS complex with a slit upstroke to QRS complex, which is known as delta wave. You can see here in this red circle. Sorry. See here the delta wave and broad QRS. The upstroke delta wave, we also known as the left-sided WPW. Okay, so next we go to the WPW for the right-sided. So we can see here, this one is sinus rhythm with very short PR interval, which is less than 120 milliseconds, broad QRS complex with slit downstroke to the QRS complexes, which are known as delta wave. You can see here, the delta wave that form is negative, so which is downstroke. So this indicate the patient might having right-sided WPW. So we go straight to the case study. So a 25-year-old male with no personal or family history of cardiovascular disease presented with cardiac arrest at hospital. So when the hospital critical care team arrived, the cardiac rhythm was ventricular fibrillation. As we can see here in the case study, the ECG has given is VF here. You can see the ventricular fibrillation. And the biphasic shock of 200 joules was applied with conversion to a regular white complex tachycardia with heart rhythm of 250 beats per minute. You can see here. So the critical care team of hospital arrived, then the patient having the VF, you can see here in the ECG, and give with 200 joule shock to regulate back his rhythm. As you can see here. Okay, so during the transport to the hospital, the patient become unstable again, presenting irregular white complex tachycardia suggestive of pre-excited atrial fibrillation. You can see here, atrial fibrillation, because there's no P wave. All right. So during the pre-treatment, so the doctor suggested to do an ECG to look out what's the patient's problem. So the patient having a sinus rhythm with a very short PR interval with 40 milliseconds and delta wave. As you can see here in the lead 2, we can see the delta wave, the select PR interval. So this patient also indicate left-sided accessory pathway, which is the left-sided WPW. As you can see here, also in the V1 is also upstroke. Okay, next. So once the doctor have diagnosed, so to further diagnose the patient, so doctor do an electrophysiological study. So 2 catheters were positioned via the right femoral vein and included decapolar 6 French catheter in the coronary sinus and a quadripolar catheter CRD 6 French in the right ventricle for his bundle activity and tracing and ventricular stimulation. So the doctor has found out this patient having pre-excitation at left anterolateral accessory pathway is diagnosed. Okay, so the doctor straight away decided to do a radiofrequency ablation. So what is radiofrequency ablation? So this treatment is similar to a microwave heat in order to destroy a small area of heart tissue that is causing rapid and irregular heartbeat. Okay. So during the procedure, an autonomic AVRT was induced. So I will show you what is it. So during the treatment, ECG, AV re-entry tachycardia. See AVRT. So this happened during the treatment. So non-sinus rhythm has been seen in the ECG, which is P wave present after the QRS complex. As you can see here, the point, the arrow is indicate the P wave. Usually the P wave is negative deflection. Usually it will show the negative deflection after the QRS complex. And the patient experiencing autonomic AV re-entry tachycardia. So this is how it's looked for AVRT. Okay. So this is the how it should be looked, AVRT, C and QRS, and then P, the downstroke one, and then T, PQRS, T, P, okay? So this is post-treatment. After the radiofrequency ablation, the patient come to the hospital to do a checkup follow-up. So the patient have a sinus rhythm with very short PR interval with 40 milliseconds. Even though the PR interval is short, but there is no sign of delta wave in the patient. There's no slate PR interval. Okay, so no delta wave present. However, the tau T wave at V3 and V5. So, however, some study shows that there's a patient might need a further treatment and management. Some of them need a medication. Certain anti-arrhythmic drugs change the electrical signals in the heart and help prevent abnormal site from starting irregular or rapid rhythm. Next, the patient also being advised to do an implantable cardioverter defibrillator, which is ICD. An implantable ICD is a device for people who are prone to life-threatening rapid heart rhythm. And last one is CRT. So most of the patient with WPW might have SCD, which is sudden cardiac death. So CRT device work by pacing both left and right ventricles simultaneously, which result in resynchronizing the muscle contraction and improving the efficiency of the weakened heart. Okay. So in the conclusion, in summary, WOLF-Parkinson-White syndrome and atrioventricular reentrant tachycardia require a trim approach for effective nerve management. Cardiovascular technology helps in diagnosing and monitoring this condition, making procedure like cardiac ablation more precise. Permanent pacemakers are often used to help control irregular heartbeat. The decision is to use a permanent pacemaker is based each patient needs, with newer pacemaker feature having tailored treatment. Ongoing research in cardiovascular technology aims to improve diagnosis and treatment method, which can lead to better care for patients. So this is my reference, and thank you.